Now it's my pleasure to introduce Shelley White-Means, also a member of our National Advisory Committee, who will facilitate this next panel.
Good afternoon. It is my pleasure to introduce our next panel from Cohort 3. This panel's emphasis is on the nurse as leader in delivering care. I was sitting and listening to our keynote speaker who was discussing issues of disruption strategies. And as he was introducing these ideas, I kept thinking about this particular panel. There is a common theme in this panel about disruption. This panel explores change strategies that can be used by nurses to reduce costs and to increase quality of care. For example, our first panelists, Barbara Resnick and Cheryl Zimmerman, are looking at change strategies that focus on optimizing function and physical activity. This is a change in the provider-patient interaction and intervention. Our second panelists, Katie White and Doug Holy, look at a change strategy that is a change in the interaction between the physician and the nurse. Our third panelists, Kathleen Stevens and Robert Farrer, look again at another change strategy. This is the change in the nurse interactions with the hospital system. Our fourth panelist, Cynthia Colbert and Stephen Setter, are looking at another strategy, another change in the way nursing practice is implemented, now changing the provider's interaction with information technology. Our strategy now is to have each of our panelists present for about 6 to 7 minutes. And when our panel completes this presentation, we will then open the audience for all those burning questions that you were waiting to ask.
The first thing I have to say, Cheryl reminded me, is that the first change we're making, group, is these are not patients, they're residents. Our study is about assisted living. There's lots of nurses, we must remember, that are not working in acute care facilities. And that probably will increase given length of stay. And we're sort of tasked just again to tell you where we are. First thing I want to remind you, for those of you who particularly weren't here last year and I'm sure don't remember, that this study is really focused on looking at ways that we can motivate nurses and older adults in assisted living settings to optimize function and physical activity. So it's moving from a focus on completing the task to getting the older individual to engage in their optimal physical activity and function. We took to heart what we were told last year. This is for the next cohort that we'll be presenting, I think, this afternoon, that you're given great opportunities to think a little differently, and we did change the way we refer to restorative care and really call it now function-focused care or function-focused nursing. Where we are now, just to give you a sense, I think all things considered, it's an intervention study, so it's always multiple challenges, which we'll talk about, but we're really currently in all 4 sites, which is lots of balls to balance and at various levels. Just to give you a sense, we've completed 4-month follow-up in one site, initiated in another, and we're kind of finishing recruitment in one and starting recruitment in another, and so it goes. We did want to share what some of our expected findings are as opposed to what our unexpected findings are. And we did anticipate that there would be some staff awareness and interest in health promotion given what the world is today. What we didn't expect was that staff who don't exercise really are a major challenge, and this is kind of helping me direct some future research, but if I don't motivate the staff to engage in physical activity, I might as well just bang my head against the wall. The other thing, I skipped staff turnover, which we anticipated. What we didn't expect is that administration turns over more so than staff. We had one facility, I kid you not, in the process of rolling out, I had to go and sit with 4 different assisted living managers in a matter of a couple of weeks, to the point where I was really, and I'm very good about dealing with the real world, but I was about ready to say, guys, this is out of hand. But I did it, and we continue to work with the facility. But I thought if there's one more, I'm just pulling out of this site. The next challenge was really engaging the staff. We anticipated would be a problem, but again, we didn't anticipate the slowness of how things move in assisted living. And I had done research, lots of research in nursing homes, some in assisted living, but if I tell you, at a snail's pace. I rolled out a very similar study in acute care, and it went like this. I couldn't keep up with them because I'm too used to long-term care, and this is just to set up a meeting takes forever. And it's unfortunately a level of professionalism. We did anticipate the usual IRB issues. What I didn't anticipate was that my university was going to change over their electronic system and decide to audit and do self-studies on everybody in the School of Nursing, which takes, if those of you who have not had the opportunity, it takes a gob of time and it's not pleasant. So we've endured that as well. And then the last challenge was resident and nursing assistant recruitment challenges. One of the things that we've really learned, and I'm sure that I will be writing a paper about this, is in the nursing home, the people that we worked with in terms of recruitment were actually more impaired cognitively than the assisted living folks overall. And we do an evaluation to sign consent, and so a lot of them couldn't pass it, and we would go to a proxy. Well, in assisted living, there's a good bit of cognitive impairment, but it tends to be a little bit earlier. They can pass the evaluation to sign consent, but when it comes to actually consenting, they get a little bit paranoid. We can't really go to a proxy, nor should we, but you're dealing with some other issues, and so that's been a real challenge where they want to participate, they won't sign papers, or they want you to talk to 12 children, don't remember, and you start from scratch. So that's just been an interesting finding. Why does anyone care? Well, bottom line, particularly in assistive living, what we're seeing is that we are providing care that essentially is propagating a decrease in function. It's a system that's a pay-for-performance system. You want mom to have her feet cleaned or her shoes put on. Nursing assistant's going to go in, do that task, and she's out of there, or he's out of there, as opposed to really thinking about function. We're providing service, we're providing care, and that's what it's all about. So actually, I anticipate we're going to see an even faster decline in function in those settings, and we know with deconditioning, decline in function, bad things happen. This is just another example of the fact that I think we as nurses and other members of the interdisciplinary team need to stop propagating this type of care and begin to think about ways we can optimize function. Our hopes for the future are to engage the staff really in how they think about and approach care, what they think about is their job and is their task. I always work with the nursing assistants to think about, you are not just providing care for people, you have expertise in optimizing this older adult's ability to engage in functional tasks and physical activity. And then to use our findings, hopefully, for a larger clinical trial that really focuses truthfully on workplace physical activity. I need to change the physical activity behavior in the staff, unfortunately, in these facilities to get them to optimize function in the residents. And then I also hope that we'll be able to take some of this, and we're already doing that, and change how we teach nursing care at particularly an undergraduate and even a graduate level. Just wanted to show you our team. Cheryl Zimmerman is here with me now, and then our other team members. I will say that the last 3 team members are not nurses as well. There are research data collection staff, and none of them are nurses, which brings a really nice alternative perspective as well. And these are just some pictures of one of our intervention sites. So you can see we have very happy residents and staff.